It is a huge honor today to be back in my favorite endodontic office in the world. What is it? Superstition Springs Endo.
Yeah.
And I'm with Jason Barney, and who's an endodontist. He went to Ohio State, and he went to his endo program in Indiana. So
Yeah.
are you a Hoosier or a Buckeye?
I'd probably say a Buckeye.
A Buckeye?
Yeah, it's easier to be a Buckeye right now. So,
Oh, and they finally figured out what a Hoosier really was.
what's a Hoosier?
And it's not even a joke. There was a lady that was doing the history of railroad companies. And railroads, they used to lay like 5, 6, 7 miles a day. So they moved too fast to introduce everybody. And if someone was running into town, they'd say, well, who are you? And there was a man named Hoosier that laid a railroad across Indiana. So it would have been common for all of his employees to say, yeah, I'm one of Hoosier's men.
Oh.
So what's a Hoosier? And this was on National Public Radio.
Yeah.
But it was an interesting book on the railroad industry. I liked it because it really underscores the value of standards, because everybody was laying railroads different sizes. Correct. So then when it went bankrupt, if your train didn't fit their tracks, it was useless. And it was later on when government started realizing that if we impose a standard, it's really value added. It makes everything lower cost because trains can fit on every track. Imagine if everybody's electricity had a different deal. And by creating standards, and you can mass produce a toaster because every plug-in is going to be standardized 110 or 120.
Right.
So it was a really interesting book. But I got to tell you, on Dental Town, we have 51 categories. And the top categories of the most activity is always your field, endo, or implants, or practice management.
Right.
I mean, and of all my friends I know in the backyard here in Phoenix, half of my friends would rather be beat with a stick than do a molar root canal. They'll do single canals.
Right.
But like my friend Bob Savage, he says, I'd rather just be shot. If I have to do molar endo, just shoot me now.
Yeah.
So why do dentists hate molar endo, and how did a guy like you decide you want to commit your life to something that half the dentists would rather be beaten with a stick than do?
Well, it's interesting.
What went wrong in your childhood?
Right, to make me want to do it. Well, I was a general dentist for a few years on the western slope in Colorado, and I think that what got me interested in endo was the magnification part, because I knew I enjoyed practicing with loupes, and I saw some cases. On Dental Town, people started to post photos of their scopes, what they were seeing when they were, doing their root canals through their microscope. And I thought, wow, that pretty much just changes everything, because if I could see all this, what could I do with dentistry? And so to some degree, I was interested in it early on into, when I had seen those photographs. But then we had a prosthodontist come to town. And he was just out of Iowa, and I can't even remember his name. And I don't even know if he stayed, but he had scopes in his practice. He put up 2 globals in the practice, and I thought, well, if a prosthodontist is using scopes, there's got to be something to it, because I knew he wasn't doing endo. So I think that kind of, I guess, triggered things, and I started to look in, and I thought, well, okay, what is endo? I was doing single canals. I was doing, occasionally a molar, and I would get in trouble, and then you would realize, this is, if I'm going to really feel comfortable, I either have to bag it and not do them, or I've got to get training. And I think that education bug that you have in you, I thought, I'm going to go back to school. So then that's when I kind of applied, got, to go and started it. And so that's got kind of what triggered it. Thinking I was going to learn all this, as we were talking earlier about, how you really get your education. It's ironic, because so much of our education is said this is how it's supposed to be. In dental school, you're taught all this stuff, and even in residency. And then when you get there, you realize, well, one, I don't know if they really even know everything, and whether really what they're teaching is accurate, because they're not out in the trenches getting, the cases, showing those cases. And then when you get there and you realize that, and then you realize, well, I don't know anything even after I get all this education, and because so much of what we do is clinically based, and how do you get that unless you're right there doing it, And so anyway, I think that's how, the long answer to your question, but yeah.
So what percent of as an endodontist, most everyone you're talking to is going to be a general dentist.
Right.
do you mostly only get molars? I mean, do people actually send incisors to the
Yeah, they
endodontist?
do. Well, obviously we get a lot of retreatments, and that's going to be. Are we good? And that's going to be, we'll get from anteriors to bicuspids. But no, we have some that will send them in. I think it depends on the person and the general dentist. I think some of them, they've realized, hey, I can get this person to, get the headache out if they're in pain or having swelling, and just get them to someone who treats it daily, and then I don't have to worry about it. Get them back and get them whether they're going to be crowned or just a restoration. So I think that we still get occasional anteriors and bicuspids. I mean, we do those a lot, but yeah, the majority of them are going to be molars and things like that.
And what percent of your workload is just retreats?
I would say a third of what we do here at Superstition Springs is retreatments.
And
Yeah.
so help the doctor. So why do you think they're being retreated? Was it missed anatomy? Was it are there just some bugs that are just far worse than others?
Yeah, it's interesting. I think that as we talk about bugs, I really believe in endo. We don't understand what causes something to go back into a refractory case where it is stable and then starts to hurt after it's been done, because you can see a perfectly nicely done endodontic root canal, and as we, on an x-ray, and yet you have no reason why it's not working, and yet the patient's complaining, and so I think that just lends itself to the fact that our obvious model is a little flawed to some degree in what causes a tooth to go and not go. And I think it's a lot more multifactorial in the sense that whatever our bodies are doing, and whether they can handle what's going on has something to do with it, but we don't really know. But yeah, some bugs probably become more comfortable in an area, because then that's what caused them to go and things like that. But yeah, I think that will become more and more of an issue as we get more, evidence on, what's causing these cases to need to be retreated.
Imagine what we'll know 100 years now when they're telling us that every 3 months they identify a new species of bacteria in a cavity.
Yeah, I know.
Just in dental decay.
I know.
Every 3 months they find a new species.
Yeah. And what causes those to be more aggressive than others, I don't know. I think, it's very misunderstood, and that's why I think it's important that you look at the evidence behind cases, because I was told, oh, you can't do this or you should do this, and there's so many different ways, whether you one-step, two-step, multi-step a case. And I think it's difficult because we don't have that information. I think that's something that comes unfortunately for the endodontic resident or the the dentist or the young endodontist. You have to have cases under your belt to see that, and even then it becomes a very difficult thing to be able to put your finger on and say, well, this is the steps you do. But to answer your question, is it missed canals? Yeah, but I could show you, 100 cases probably just in our own practice where a missed canal hasn't done anything. So what does that say to the model? I think it's a little different.
I remember when I opened up in 87, you would see all these elderly people with silver points.
Exactly.
And there's no way it could have worked.
Exactly.
And they were in there for 25 years.
If not longer. That's why I say I think that, obviously I'm a little biased because what I see here at my practice is the bad ones because they're hurting or they wouldn't be here. But how many of them are out there just walking around our communities without problems? Probably a lot.
So my first endo lecture in 83, the endodontist said, endodontics, it's like Stevie Wonder picking a lock.
Yeah.
And you opened up with what turned you on was magnification seeing. So is it no longer Stevie Wonder picking a lock?
No, not at all. I mean, obviously there is some fill to some cases where, visibility is difficult with a person who can't open their mouth or that. But for the most part, I start under the scope and I end under the scope. I'm never not working without looking through the scope. And so that changes it to where I know where the canals are, which can be a great thing. And then sometimes it can be a bad thing because you think, well, there should be a canal here. And so then you start really looking and there's not. And, once you remove tooth structure, it's gone. It's not coming back. And so I think that it's that balance of understanding how aggressive do I get looking for canals and how aggressive do I, or how conservative do I get where I say I'm not going to go after too much because, I could cause damage to that tooth.
So you said your microscope is a global?
Yeah, we use
That's
global.
out of St. Louis?
Yeah, I'm not for sure. I think it is actually, yeah.
Do you know how much that costs, and is yours mounted on the ceiling? Do you wheel it from room to room?
Ours is mounted from the ceiling. They can be mounted from the wall. They can be wheeled. Usually a microscope, it varies. I think you can get them as low down as, I want to say 15,000, but then it can go up as much as 50,000, for one scope. Ours is what we call a five step, which means there's 5 levels of magnification on there. If you were to ask me what they are, I wouldn't be able to tell you. I know that I usually function under what is a 0.6 and a 1, which is, it's a lot stronger than like my 2.5 loops that I have. The 0.6 is much stronger than that. So I don't know, it's a little different going from because I don't know the magnification.
So how do you rationalize this? Could a general dentist, because half my friends won't do a molar,
right?
But the other half that are doing, do you think you could do the quality of endo you're doing without a scope?
No, I don't think I could. I really don't, and that's why I think the scope kind of changes. Well, it changed everything. It changed not only what I saw as an endodontist, but like I said, I feel pretty confident in my general dentistry skills. I did it for 3 years and, did plenty of, and I don't know if I'd dare jump into any of that without a scope. I would dare say, if you were to say, okay, you can't be an endodontist, you got to be a general dentist, it would all be done under the scope, because I feel like what I can get out with decay, and that's another thing that I think my general dentist kind of like when they send me cases is, I remember when I was a GP sending out my big decayed molars to my endodontist, and they'd come back with the decay and it's still there and the root canal done, and I thought, well, that's fine. I'll take the decay out, but my cases don't go back that way. I usually, not usually, all the decay's gone that I can excavate under the scope and ready to be restored back to my GP, because I think that I understand how big it is to use a scope with that. But going back to, your question, I don't think it would be, I would have a hard time doing a root canal without my scope.
And the other people excited about the scopes are the ergonomic people, because
exactly
they look at me, I'm 53, I completely trashed my neck. I just always was hanging my head over. Yeah. And now I have to do yoga 3 times a week just to get my neck pain, and you guys are looking in like a submarine, right? Yeah. So you're saving your neck.
I think the ergonomics of and with your posture, there's a lot of pluses with the scope, and that obviously is nice. And but we still have the same problems because you'll catch yourself even leaning there. But compared to that, there's no question.
I want you to talk to the general dentist. Yeah. There's marketing is huge in dental town. There's a lot of advertising, and there's so many file systems. When you go to the dental conventions, you probably couldn't even count them all. There's got to be 25 more.
Yeah, I don't even know. I don't. I get lost.
And now we see so many of them, like the one file. Yeah. So now there's like one file. Can you do a root canal with one file?
Well, I think you could if you understood what you were doing. I try to limit the amount of files I use, not just because financially it makes more sense, but two, again, the more you take a file down into that canal, I think you're removing tooth structure that potentially could damage that tooth. So, I remember when I got to dental or my endodontic program, it was like, okay, what's the recipe? Do I do, an 04, 20, and then just go up the ladder? And I thought that's how it was. But in all reality, that's far from the case. It has much more to do with how do I effectively clean. But even then, we know we're not cleaning everything. But how do I get out nerve tissue if that's my goal? Because if a patient comes in with a irreversible pulpitis, I want the nerve tissue gone because I know that's going to give him or her the most relief. And how do I get to that point? And I think that the file systems, if you're smart enough in the sense of looking at what's my file doing, so like I try to get away with, I don't use real aggressive files. I still use the old tried and true profile system.
Tulsa Dental Program.
Yeah, which is a landed system, doesn't cause a lot of damage to the tooth. It definitely takes a little longer to get down, but it's used as a final file where I've used like an F1, from the S1, S2. I don't use the S1, S2, but the F1, if I can get a hand file 20 down, I know the F1's probably going to go, and I'll get that down, and then I'll overlay that F1 with just like a 3504 file, and then I fill with a 3504. So I'm really only using 2 files on my cases that I can get a hand file 20 down. Now, with that said, not all of my cases I can get a hand file 20 down. And so that, real easy. And so then I will incorporate something like, the Pathfinder series, which is the real small ones.
Who makes the Pathfinder
I think
series?
it's Tulsa. And, or any type of O2 type of file that, you can start out with a 10, 15, 20 and get to length. That makes it a little bit easier. Then you can maybe get your hand files down. There's no question that for general dentists out there, that there's probably some sort of rotary system that you can use through the whole case and not even go to hand files. But I don't see the need for that. And again, we're talking about a lot of money when you start going through, if you're using 5 to 6 files per case, rotaries, we don't, I don't know. I think that you don't need to do that. It seems to be overkill and you're just spending money you probably don't need to be spending.
So what would you say? Sometimes dentists in Oklahoma tell me that they're the state where Ben Johnson in Tulsa, Oklahoma, they invented rotary endophile.
Right.
And I was in Tennessee last week, and they were saying, no, it was our state.
Yeah.
It's John McSpadden.
Was it McSpadden
in
there?
Chattanooga, Tennessee.
Yeah, right.
Who do you think gets bragging rights to start endophile, Oklahoma or Tennessee?
I've met Ben Johnson once in our residency, and it was one of the most fascinating probably lectures we had when he came, because all he talked about was hunting lions, which was actually quite fun. I don't know.
Hunting lions like Cecil the lion?
Oh, yeah. He went out, and I remember he told us a story of he had a guide find it, and he flew out and went and killed the lion, and I felt like I was talking to Ernest Hemingway. But it was actually kind of fun.
He's lucky he wasn't the last guy that did it, huh?
I don't know who has bragging rights. I think that McSpadden is down there in Chattanooga, and he might be able to give enough arguments on it. Dr. Carlson here had met, I think, Dr. McSpadden. I never met him.
You know what I like the most about both of those guys? When I got out of school in 87, I was so frustrated in molar endo. I called John McSpadden one time in Chattanooga, Tennessee. He said, well, I wish you were here and I could show you. And I said, I can afford a plane ticket, but I can't afford your course or your hotel, whatever.
Right.
He goes, well, just fly out and stay with me. So he let me come stay at his house. And then I was calling Ben Johnson with another question. He said the exact same thing. I said, well, I can afford a plane ticket, but I can't afford a hotel, whatever. And Ben said, well, just fly out here and stay with me. Both of those guys let me sleep in their house and spent the whole day with me in their office. That's how much they love their profession.
Yeah.
I
loved when Dr. Johnson came in and spoke to us. It was almost like I said, I felt like I was talking to a celebrity, and it was fun. But, I think, talking about Dr. McSpadden, I still use the McSpadden compactor a lot of times, which is that reverse headstrom type of file that will push gutta percha, So sometimes, like if you get a gutta percha case where, especially like on a number 8, if it's got a large canal that's got to be obturated, you can take that McSpadden down with the gutter. So you backfill, and if you have voids, you just take it down a couple passes, and it pushes very nicely and compacts. And it's a great instrument.
Let me ask you some of the things that are confusing. Some dentists say that when they're doing a root canal, they want to keep going back with their 6 or 8 or 10 file, going out the apex to make sure they have patency out the end.
Right.
Then other people scream and holler and say, man, you're pushing infection out the apex. That's why you have post-operative discomfort. Don't do that. Same with sealer. Yeah. Some people, they want to see a puff of sealer out the end. Yeah. They had patency. And other people are saying, well, that's why your patient needs Vicodin, and that's why they were sore for a week. What's your thoughts on Are you pushing bad stuff out the apex? Or?
I don't think it's bad. I think it's all, you're going to get some inflammatory response regardless of whether you push anything past the apex or not. I mean, I had one professor in my endo residency that believed in the dental chip packing. So you kind of reverse your file and push it and then create kind of something to back push against. I don't think there's anything wrong with that. I mean, the bottom line is it goes back to what I said before. I don't feel we know exactly what's better or best. It's just a matter of what is working in your hands. and you have the cases to support it, because I can, like we said before, we can show plenty of silver point cases that have went 30 plus years, and yet we don't know why. I've been reading a fascinating book that talks about how sometimes the evidence isn't in, being able to show all these cases. The evidence is in the cases that don't make any sense. Why is that working? And so I think that just to some degree, we had John Cotomy, who's a pretty incredible endodontist out of Durango, come and speak to us here for our Endodontic Association just in Arizona. And I mean, the cases he was showing, it goes back to the whole, they shouldn't be working based on the model that I was taught, but yet they're working just fine. And I think that there's a balance between, I think what we do know is the more aggressive we are taking away tooth structure, we have problems. As we all know with those big silver fillings, I mean, I look at the ones that were placed, even though I have nothing against those because they actually work. They stay sealed, but eventually they start to wear and they break, and then you're moving into a little bit, a crown, things like that. And so being conservative is probably a better step than not. But as for pushing stuff past the apex, I don't get too uptight about that. My goal is to be patent, and that's what I have always done. That's how most of the endodontists who trained me do it. Only a few believed in the packing. So
this is on Dentistry Uncensored, so I always like to ask the most controversial questions.
Oh, yeah.
Not anything
Let's
everybody
go.
agrees on. Some people say, okay, root canals are painful. I always give a standard script for Vicodin or Percocet. And every year of the top 10 most prescribed pills in the United States, going back 20 years, hydrocodone's always the number one. Other people scream and yell that, that this is a cause of addiction.
Yeah.
You should never do narcotics, yada, yada, yada. If you did 100 molars, what percent would get a pain prescription afterwards? And what would that be?
Yeah, this is a good question, because I think we fight with this because there's some people that believe we're the ones that we're contributing to this addiction. The problem is how do you viably say, well, this person deserves a pain medication and this person doesn't? I think that's hard to do. Most of the patients that come into my practice are in a lot of pain. And so to have them, we're trying to fix them, but for the short term, most of my patients are getting some sort of pain management, whether that's a 600 to 800 milligram ibuprofen prescription strength on top of something like a Vicodin, or in some cases even oxycodone and that. So
Oxycodone, you mean Percocet?
Yeah, Percocet.
Not OxyContin.
Yeah, Percocet.
Yeah, Percocet.
Yeah. Well, and especially our
What percent would you give a narcotic?
I would say if it's, they come in pain, they're leaving with it. And so it's closer in my case to, 85 to 90%. Now, second treatments where they come in and they're asymptomatic. So like if I have patients who come in and they are not hurting because we've had them on, they've already been through the bad part and we're now just obturating, they're not leaving with anything. If they come in asymptomatic and they've noticed that there was an infection on an x-ray, or we notice that they have a sinus tract that's draining, those cases usually are not going to have a whole lot of postoperative discomfort, and so usually those patients don't.
Okay, I want to go into another area that's incredibly controversial.
Yeah.
You can't get anybody to agree on this. Okay, they're post. Some people say the on molars, or not. Sorry, I said molars, but post.
Just a post, yeah.
Many people on Dental Town believe that the only function of a post is to fracture the root. It has no other function.
Well, we're talking metal posts?
Yeah, metal posts.
Yeah.
Some people say the post needs to be there to hold the buildup. Mm-hmm. Some people say, post should only be fiberglass.
Yeah.
So let's talk post. Is the only purpose of a post to fracture the root?
I've seen plenty of them, that's for sure. We get a lot of fractured roots from post placement. I will say this, though. I am a proponent of, especially on an anterior case, because there is some research. And again, I'm not a big research guy, so I don't even like saying it. But I listened to, there was and I'm going to brutalize their names. But Dr. Schwartz, or Rick Schwartz out of Texas, did a paper. He's an endodontist with I think it's Marga Ray is her name, and she's out of in Europe. And they did it on fiber posts, and they talked about that there's some evidence out there that fiber posts may actually strengthen the root. and give some sort of I don't want to say strengthen it, but that maybe having fiber posts placed almost like rebar is placed in when a building's being built to hold and strengthen it. And there might be some evidence that, because obviously fiber posts have a little bit of movement, such as dentin, and so maybe there's a benefit for that. Now, I think that that's something that is very controversial because on many levels. But as for metal posts, and again, I think that it goes back, are we removing tooth structure to put a metal post in? Because if you're removing tooth structure to put the metal post in, then I don't think it needs to be there. It should be a passive fit, cemented, you know what I mean? And in that case, the fiber posts seem to be, I don't place a whole lot of metal posts because I don't think I was trained very well to do it. Now, cast posts and cores, I've seen some of those go a long time. And so what's making those things last? Maybe it's that passive fit. I don't know, but if a post is being placed by me, if it's been asked by a general dentist, it's a fiber post that gets placed.
What brand?
I could show you. I don't know. I mean, it's like the Parapost brand, I believe. It might be, but it's a tapered.
But you see something that I always think is extremely strange. Like, you'll see someone with a lot of worn down teeth.
Mm-hmm.
So to treat the worn dentition, the dentist will prepare each tooth for a crown.
Yeah, right.
And it's like, does that make any sense? You have so much wear, I'm going to stick your tooth in a pencil sharpener.
Yeah, right.
And then to make your tooth stronger,
I'm going to
drill
out the middle.
Bore it out.
Yeah.
So I can put this big old strong metal post.
Yeah,
it
does make sense.
Those don't make any sense.
And I don't think it does. And that's not where they're needed. I think they're needed in a case like, a good example is, okay, so a patient comes in. I'm dealing with this because my boy just got hit with a baseball, and so he's had a lot of trauma. Now, what if he got hit when he was, let's say, 8 years old, and number 8 got knocked, and it's an immature tooth, and we're trying to, and we're trying to get some dentin growth because we know that canal is wide open. So let's say later on in life, it stunts it, and it's always going to be a wide open canal. A fiber post, and it's interesting because the Ray paper I'm talking about that she did, she's not just placing one post. She's literally placing one big post in the middle and then accessory fiber posts on the outside of it. First of all, she's backfilling with the dual cured type like we have a Reliex product here, but it's just got to be dual cured. But you backfill with the Centrix tip, you place your main post, and then accessory posts around it to support it. Because again, going back to like she talks about in the paper, and this is way over my head, but the C factor, you're going to have less of it because of the feel that comes from those posts.
Explain the C factor.
Well, I think the shrinkage, so if you have one metal post, or not metal, excuse me, but one fiber post, and then the rest of it's that dual cured composite, you're going to get some shrinkage on that. Whereas if you have less of the actual dual cured composite in there, it's not going to have as much because the bulk fill is going to be those fiber posts that are already solid as, with some give. But anyway, that's a case. So like, let's say a number 8 immature tooth, you have a wide open, canal. Those cases, when I see them, when I finalize the treatment on them, they're getting a fiber post with accessory posts around it and then backfilled. And that's how I do it.
Okay, now I'm going to get you in real trouble.
Yeah, get me in trouble.
A lot of dentists out there, probably half of them, say that when you do a big old MOD amalgam, it'll last literally 35, 40 years.
Mm-hmm.
A bunch of the other half will never do an amalgam. They're metal free. They say all those amalgams fracture the teeth. They only do composites.
Yeah.
The amalgam people say, yeah, your composites have recurrent decay in 6.5 years. That's all they last. And they say, and you have recurrent decay, and endodontists love posterior composites because it's double their business. And then the composite people say, oh no, the endodontists make a living from all the teeth fractured by amalgams.
Yeah.
So are you pro composite, pro amalgam, pro both?
Both.
Who made you more money? The guys placing all the MOD amalgams or the ones placing all the MOD composites?
Well, I would say it's even because I'll get plenty of cases with the MOD composites where they're coming in and they're still very sensitive to hot, cold, and that's not getting better. And we get plenty of broken teeth. I mean, the bottom line is what lasts, and nothing lasts in dentistry. I mean, we can go back, and as great as the amalgams are, as it pertains to that, I do think they're durable. They do have their negatives. They break teeth. It seems to be that at the time, much more tooth was removed to get them in there, and maybe there's something to the composites in the sense that if you can if there is a term, minimally invasive, you can take away less tooth structure to get those to work, then that's great, and I think that we're seeing that's why a lot of people are jumping on board, is because you can be a little more conservative, I think, if that, again, a term, and place those. But equally, I would dare say we're seeing them both.
So you would say you're neither pro-composite or pro-amalgam?
I place both.
Work?
I place both.
You place amalgam buildups?
Yes, we still do.
And composite
We
buildups?
still do. Yep, there's a reason for it.
You know how we were joking about how a dentist will bore out a tooth
Yes.
to strengthen it with a post?
Yes.
The patient has worn dentition, so they'll file it down. There's so many dentists out there that you're talking to right now that they have this deal that every root canal tooth needs a crown. And then I'm seeing these lower incisors, and after a root canal, when they're done prepping a lower incisor for a crown, about the only thing sticking out is the gutta percha.
Yeah, you might as well just take that tooth out.
Yeah, so talk about when does a root canal need a crown, and when does it clearly not need a crown?
I think it's my thoughts on it. Obviously, a posterior tooth that has, and again, when are we doing a root canal on a posterior tooth where the only thing there is the axis opening? Usually there's either an MO on it or a DO or an MOD of some sort, or it's already had a crown. But if like an anterior tooth where a patient gets hit and it dies and you need it, and the root canal needs to be done because it's become infected, I don't think those teeth need crowns. You can do your access opening pretty small on the back side, and it's going to have one composite, and it's going to be right off the incisal edge, and it's going to be little. So that crown doesn't need to be done. Even to some degree, I've seen some molars that have become infected and root canals done, and they were so minimally restored that I don't even know if a crown was needed on those, because, again, tooth structure is being taken away, a lot of it, just to put that crown on there. But for the most part, I think the more restored a tooth is, meaning if it's already got existing restorations on it, the crown is needed. And the reason why the crown's needed is it does seem to do a little better job of sealing our root canals, which is really ultimately why a crown, I think, works well and why we recommend it. It's not because it's strengthening the tooth. It's because it's covering a little better than some of those restorations are going to do, and there's a chance of leakage. That's my opinion, but whether that's...
Okay, I see this posted on Dental Town all the time. Since 1998, it's confusion. They stop and they take a picture. They took out an MOD because of recurrent decay, and they got it all cleaned out, and they're getting ready to fill it. But they see a black line on the bottom of the floor, and they weren't expecting it.
Right.
There wasn't pain.
Right.
There's a black line. What do you do when you're placing a filling? You remove the decay, and there's a black line on the floor.
Well, I think that, at that point, the patient's numb. What I was going to say is if you are suspecting crack, I think it's important to get pulp testing done on that tooth, whether, which can easily be done by a general dentist, and figure out what's the status of that pulp. And what I mean by that is I do believe that if you're suspecting possible crack, and it's testing with even a hypersensitivity to cold, there's a good chance you may set that off. And so those are the ones you want, at least baseline testing before. But as you said, the patient's asymptomatic. You take out the cavity, and there's this crack. Well, obviously restoring it, and I think that having the conversation with your patient, look, we noticed a crack. If we get any of these symptoms, possible cold sensitivity that lingers or bite sensitivity, we need to be pretty aware of that and track it that way. But again, is there anything out there that says this is the best thing to put on top of it? Do I do an amalgam? Do I do I don't think that the research is there to say this is what you should do.
So you would take a picture, show the patient, discuss it.
Yeah.
But let's say that you do the filling and it is sensitive to cold and it lingers, a sensitive bite.
Yeah.
And it has that fracture. Is that an extraction or?
No, I don't think so. I mean, we as endodontists, I wouldn't just automatically commit that to an extraction. Now, where it becomes a problem is if the endodontist goes in, because we're talking about it going across the pulp chamber, the roof, basically. Now, if it's dropping down into the pulp pulpal floor, but you're only going to know that once you open it up and start a root canal to look at that, or going down a canal system. Then that changes, I think, your success rates. But the way I look at those teeth are, again, you look at the symptoms. If it's vital, and before it started, and it's just now become hypersensitive to cold, so you now are labeling it as an irreversible pulpitis, let's say, and you open it up and it just stays on to the roof, there's nothing wrong with a root canal and the success rates on those.
Okay, address this referral issue. I'm looking at this patient. They're in pain. It turns out it's a root canal that's failed.
Right.
How can I be more clear? Do I send this to an endodontist for a retreat or an oral surgeon for an extraction and an implant? How are you assessing this? When is it? Because you don't want to waste your patient's money.
Yeah, absolutely.
So someone already did a root canal and it didn't work.
Didn't work.
Do I send it back to the endodontist, say, hey, try again? Or do I just say, pull this baby, go titanium?
Well, again, there's a lot of factors that go into making that decision.
I didn't say any of my questions were good.
Yeah, right. I'm going to get in more trouble trying to answer these. No, I think that being evaluated, I think, is minimal. We have here at our office, we have 3-dimensional scanning. Most of our retreatment cases get scanned. Not all, but most. And they get scanned for different reasons. One, they get scanned to verify that we're not dealing with potential crack. And I'm not saying that the scanners show that through scanning we see cracks, because that is a big marketing scheme that these scanners are trying to say, oh yeah, you can tell if it's cracked. I don't see. What I do see is the bone, and I see the response of the bone around it. And if I see a tooth that has beautiful bone from basically the mid-root all the way occlusally, there's a good chance, and yet you have a radiolucency at the apex, there's a good chance it is just endodontically related, and a retreatment can fix or help repair that. So that's one factor, is I think scanning has helped us make our decisions a little bit easier. Costs on scans are down to where I don't feel like patients are getting, having to spend a lot of money to be able to get that information. And then two, one of the things that we do, and I would say for endodontists, this is probably going to be controversial, but let's say you are on the fence where you don't know, will this go to the distance? Is it better to go to an implant? Because by no means am I afraid of implants. If anything, I'm probably a little more, because I saw the benefit of implants when I was in practice as a general dentist. But I would dare say that when you see a case that's questionable, we'll open those cases up and place calcium hydroxide and evaluate. Do symptoms improve? Do we see improvement of if it has a radiolucency? Do we see bone being repaired? Do we see osseous healings occurring? Symptoms are going away. If there was a sinus, all these things, and then at that point, we can commit to saying, hey, look, we're going to keep this tooth. And for a patient of mine to jump into that, they're really not investing a ton, because if it doesn't work, we're not doing the root canal. So, yes, they're out time. So if that's a problem. So, I think there's ways around it if you're really worried. But again, to answer your question, it's not just you should go to an implant or you should just save the tooth. Because a lot of those we don't save. A lot of them become implants.
Some people... it looks like data can be shown by insurance companies that as implant placement goes up, the numbers of apicoectomies done in the United States is going down.
Oh, yeah, I would.
Is that a one-on-one? Is that implants are putting downward pressures on apicoectomy retrofills?
Probably. I would say that's definitely something that's happening. I think you could even argue that root canals probably will go down, because as more and more dentists decide to place the implant, to that person, it may be easier to go to the implant. It may not be the right answer, or the right but it's an option that is being done. The other thing is I think with apicoectomies, we used it as a, kind of this last-ditch effort to save the tooth. And I look at an apico as, if I know it's got a high success rate after, going to an apico, then that's when I'll push it. But if I look at that and I say, this is possibly a fracture, there's no way I'm attempting an apico on it. We're going, if I suspect crack or fracture, it's almost guarantee that tooth's coming out.
And are you pulling them and placing implants? Or you...
I don't do that. I think it would be fun to do, but I just figure my specialty's doing the root canal and making a decision whether I can save that tooth for a long period, and then if it's not, then it goes back to the general dentist. I usually will call them and say, hey, look, this needs to come out. Would you want to do it, or do you want me to send them to somebody else?
I want to switch to warranty. Some consumers think that everything should have a warranty, that it should last 5 years or a period of time. Is there a length of time that you think a root canal should last, or the patient should get some of their money back?
We're pretty fair here. I mean, I've seen the extremes where if it goes 2 years and it's hurt and it doesn't work, they're not getting their money back. We usually still bill out an incomplete. If it doesn't last 10 years and it's not working, we're usually pretty fair to that patient. We'll
10 years?
Yeah.
What do you mean?
Like if they come back and it's not working, and let's say I have to go back in it, I usually don't charge them to go back in it.
For 10 years?
Yeah, because a lot of times...
Are you serious?
Yeah,
I've never heard of that.
Yeah, because a lot of times, I feel like it's my responsibility to keep that tooth for...
Well, a lot of dentists in downtown, I don't know if I trust my dentist. He'll do a root canal. It'll fail in 6 months, and he says, well, I did my best. I tried. It's all I can do. It's not my fault. And they're like, well, maybe if you had to warranty it for 3 to 5 years, that maybe the endodontist wouldn't have done the root canal.
Yeah.
I mean, what do you specifically do if you do a root canal on Fred, and 6 months later it's got to be pulled?
Yeah, it's billed as an incomplete, which obviously has a fee associated with it, which if you look at the incomplete fees, and we got, you talk insurances because that's what we see there. It's usually, around $250, $300 for, a third of what a root canal maybe is. It's kind of the give or take. And so that's usually what's billed for that first. And then, reimbursement back to the insurance company, or if the patient's paid out of pocket, it's back to the patient.
So you do believe in a warranty? I've never heard of anybody with a 10-year warranty.
Yeah, we do. We're pretty, like I said, I don't know. I came to this practice, and I knew Dr. Carlson and Dr. Hells prior to it, and I knew they were, pretty neat guys, and that's kind of what they've done. We try to keep.
Your website has amazing cases on there. What's the name of that? What is it?
There's the Endo Blog.
What's the www on that?
It's the endoblog.com.
The endoblog.com.
Yeah. Mm-hmm. That's ran by Dr. Hells.
That's Dr. Hells. Mm-hmm. And tell them about that site.
So he started that probably not quite 10 years ago, but probably 7 or 8 years ago, and he just started posting cases he was doing, and it gets a lot of people go to it for information, and he'll just post cases here and there, and people comment on them, and he gets a lot of followers from that. I don't post a lot on it because I usually just give my case to him and let him do it if it's an important case. But yeah, it's neat. He's got some good stuff on there and some stuff that's controversial.
So I'm trying to get you in as much trouble as I can.
Yeah.
This one's going to be a doozy. Ben Johnson shows the best lateral condensation root canal ever done. It was, I think some guy got literally like 50 accessory cones, and he magnifies that, showing it's just all, spaces and leakage and black.
Oh, yeah.
And then he talks about his gutta percha carriers.
The thermophils.
The thermophils, and how that's just better. Some people say that, some our friend Joe Dovkin, who passed away.
Yeah.
He said, 3-dimensional endo, you got to be a squirter. If you're not using a hot gutta percha gun, if you're not a squirter, you're not doing it right. There's lateral condensation. There's vertical condensation. There's squirters with obtura. There's gutta percha on a cone. How's a dentist supposed to make sense of this? What are you obturating with?
Well,
and then some of the people who are not endodontists say, my endodontist doesn't like those carrier-based gutta perchas because if it's a retreat, he can get out gutta percha real easy. Yeah. But if she's got to go get the carrier out, that some endodontists say that takes them twice as much time, and sometimes they can't even get them out.
Yeah.
So
it can happen.
What should I obturate with? And can you get carrier gutta percha, like a thermophil, Does that make it significantly harder to retreat?
No, not necessarily. I mean, when I was first starting, it did. I used to complain all the time, and I remember I was at a course in Joe Buchanan, who I think is the one that kind of worked a lot with the thermophils. But I remember he was saying, if you can't get these out, you're incompetent. And I thought, well, what a jerk. But then I realized it's true. Because you can't.
Joe Buchanan or Steve Buchanan?
Steve Buchanan.
Steve Buchanan. Okay.
Yeah, Steve Buchanan. And I knew that he was probably right, because I can get them out pretty easily. There's occasionally some I can't, and I think it has a lot to do with the way I'm getting down the canal system. The key is if you can get past them with a file, you're getting them out, because now you're painting and you haven't ledged yourself out. It's the ones where I think you ledge yourself and then you can't get past them that you're in trouble. So I think if it's a general dentist trying to do a retreatment and they're working on the key is don't get real aggressive with file sizes trying to pull them out. I think you got to get past them with a file, like even a 10. If you're painting with a 10, that thing's coming out, because then you can always get a 10, 15, 20, and then eventually that thing will pop out as you start taking rotaries down it. But as for your question, what's the right way to obturate? I don't think we know. I really don't. I mean, I'm a single cone, place it, if I take it to a 3004, I'll place it, and then using a System B, heat it, and then backfill with the Obtura. But what Dovkin said is true. I think the only way really to get three-dimensional is to squirt, because that's the way you get it out, to get all that stuff in there. And as for thermophils, everyone bags on thermophils, but yet they work in so many cases where, especially those skinny cases, I mean, where you can't be taking it to a 3006, but you're at a 2504 because of a significant curve. How are you going to get anything down that? And thermophil seems to work in those cases. So I'm not really a negative when it comes to that. We retreat everything. I mean, I've seen nice cases where I know that they use single cone or ladder, and so to say one way is better than in another is not right. So.
You miss Joey D?
Yeah, that was kind of a bad deal.
It's funny. I went to Creighton with him.
Yeah.
And he's the only, 100% on endodontist, but almost at all dentists. He was the only guy where his whole life he only had one mode, and it was dentistry.
Yeah.
I mean, the guy, if you talk to him at 6 in the morning or at 7 at night, didn't matter if Monday or Sunday, he was doing something with endo. I mean, the guy just ate, lived, and breathed, died, slept. I mean, it was just an amazing man. So we talked about pain meds afterwards.
Yeah.
What about antibiotics? If you did 100 molars, I mean, do you just shotgun everybody with a Pen VK?
No, I don't. I'm usually pretty conservative with the antibiotic. They've got to have some sort of systemic type of thing where either we're getting quite a bit of swelling, obviously fever, things like that. But no, I think that to patients, they feel like maybe when you give them an antibiotic, you're helping them out a little bit and that you really care. But I always usually have a pretty good conversation that I think is better, where you say, look, there's not a lot of research that says if we put you on an antibiotic, it's going to really help you, especially on a case where there's no systemic factors, there's no swelling, there's no, and usually just anti-inflammatories and if needed, a pain medication is enough,
What do you say about this? There was a $1 million settlement in Kansas. A person had an extraction. It was a canine, and after the extraction, they didn't give an antibiotic, and the infection went back in the brain.
Yeah.
They died. Some people believe that. What do you call that? My instructors call it the Bermuda Triangle, canine to canine maxillary. They're saying that there's the veins there go back into the head. Some dentists believe that all extractions, all root canals, canine to canine on the maxilla, have to have an antibiotic afterwards. And again, this case in Kansas settled for $1 million. The patient died like 3 days later in the hospital.
Right.
Do you agree with that? I mean, just because the lawyers sue for something doesn't mean it's right.
I was not taught that, just to prophylactically give an antibiotic from canine to canine. I wasn't taught that. I was taught to go off of more of the regulation that, not regulation, but if there's systemic factors, swelling, fever, things like that, that's when an antibiotic can be considered. But a case like that's going to open. I hadn't heard that, but that could open, because, again, sometimes we treat based off of things that we don't want to deal with. And that's unfortunate because I think that what's a bigger problem is resistance that we're seeing more and more of, and antibiotics to the microbiologist is a scary thing, because bacteria, they're going to live. They live wherever, and to get rid of them, we're not getting rid of them,
Back to Kansas, there was another $1 million lawsuit. A person had Sargeni. It went out the apex. It pickled the inferior alveolar nerve. They got the full amount. They got the full $1 million coverage. Do you still see Sargeni, or is that
I haven't
gone?
seen it for a long time. I haven't.
So it's kind of gone now?
Yeah, I honestly haven't. I've seen it before, but I won't. But again, that was in my residency. I saw a couple cases, but and maybe Dr. Carlson could speak more to this, but no, I have not seen Sargeni for a long time. And what's ironic is Sargeni can do that, but so can calcium hydroxide going out. It can cause a lot of problems. I've seen that being placed into the inferior alveolar canal, and that causes numbness and things. I've seen gutta percha with sealer do it. So, Sargeni, I think the AAE came out pretty hard against it, but it would be interesting to see, and I go back to this all the time, how many cases of Sargeni worked and are out there and no one knows about them, maybe
right. So, a lot of endodontists will say that, when you ask them an obturation question, they'll say, I don't care what you put in, root canal is about taking out the infection, not about how you obturate putting in. As far as taking out the infection, in marketing, we see people talking about, instead of just using bleach, now warm bleach.
Yeah.
Or there's agitators
Buffered.
For bleach.
Yeah, or all these different
ultrasonic
things.
vibrations.
Yeah.
Any of those got your attention? Any of those you think are worth the money, or do you think it's marketing hype?
I think it's more about trying to. No, I don't. In the sense of you've got it. Everything's got like the Endovac. I remember I used Endovac for 6 months on my in my residency, and it seemed to always, it took longer to use, and I thought I was doing a much better job cleaning. I don't think it really does. I think that one of the things I use, and I think I use it not because I feel like I'm getting better success rates. It makes my job a little bit easier. Is I do use just sonic with the endoactivator because I can get calcium hydroxide in places, at least get it down the canal system. So I'll use the endoactivator, and it's fairly safe because it's a plastic tip, so you have minimal risk of breaking it. And so I'll use that to place calcium hydroxide, but I don't think it increases my success.
I'm just trying my hardest to get you in trouble. I'm just going to throw somebody else. So there's an endo system called SafeSider by Barry Musicant, and his whole big deal is that his don't break because I think they're going
the reciprocation type deal.
And his claim to fame is that the nickel titanium is going all the way around.
Yeah,
and so he calls them SafeSiders. Some people say I'm going to hand file the rest of my life because I don't want to file the break. Is file breakage a problem? Is it a problem with you? Do you get a lot of molar scent where the file's broke and you got to try to get out the file?
Yeah, but I'm not a big. I was taught to get files out, and actually had an endodontist who would come, and he was. He was really good, but it's hard to get those files out. And what I will say is, where I kind of draw the line is if I'm going to have to remove a ton of tooth structure to get a file out, I'm not going after it because I've seen, at least in my hands, too many cases where perforations were done because I'm trying to get out a file that may or may not cause problems. Now, the flip side is if a patient comes in and you're retreating a case and they've already got, an abscess or they're in it and it's symptomatic, a symptomatic, abscess, then becomes more of a problem, and those are the cases where possibly apicos you could consider. I still usually retreat with calcium hydroxide on those cases and try to get past that file some way, and if not, then you go to the apico. But yeah, I'm not a big file removal guy saying you got to take them all out, or if they break, you're in so much trouble, you might as well just start paying money back because I'm not. I've seen too many cases where it doesn't do anything. If a file breaks, as long as you're pretty upfront with your patient, it's part of, treatment. Now, there are ways to prevent file breakage. I think that single use becomes something you may want to consider with the rotary files, as well as, hand filing. I mean, if you're down with a 20 hand file, for the most part, you can almost guarantee that, not guarantee, but you're going to have less of a chance of breaking with a rotary because you're already.
Or do you only use your files one time?
Yeah, for the most part we do. Now some like a 4006, if it's if you used it, a lot of times they're not engaging much. So we kind of make that call but like my F1 that I use, that's usually single use because it gets used. It gets used in my case because it does a lot. The majority of my, I hate to use even the word cleaning, but it's cutting some, and those are the ones. But my hand files, I hand file everything up to a 20, and then Headstrom 20 usually is down. So the canal system's pretty open before I introduce rotary to it.
I've only got you for 4 more minutes, so switch to irrigants. What irrigants do you pretty much always use on all your endos?
Obviously, I use full concentration sodium hypochlorite.
You don't dilute it.
I don't dilute it, and then I use EDTA as a final, and then, well, not a final, but I usually will EDTA, and then I use a drying solution. It'll be alcohol as a drying solution at the end. So just through the whole procedure,
rubbing alcohol from Walgreens.
Just
your little...
Might even be Everclear. I don't know. It just
really?
Down in, it just dries it out, and that gives me and it's not usually to clean, or it's just to dry the system out. And then I paper point the alcohol out.
So you're not using chlorhexidine?
I don't use it. I don't think it does. I don't know if there's much benefit for it. I mean, some people really like it. I shouldn't say I never use it, because sometimes on your open apice cases, you got to be very careful because you can get an accident with sodium hypochlorite. So yes, it's used in cases like that, 2% chlorhexidine.
Another diagnosing treatment. I'm just trying to go off all the questions I can remember on the endo threads.
Yeah.
How were you thinking? What goes through your mind when you're thinking, I can do this in one appointment, or you know what, I should put some intermediate
calcium hydroxide,
and let this thing heal for what? What's going through your mind?
What I will say is, if I knew that, we would be in business, because we could figure out how to do all endo. That's the hardest part, and I don't have answers for that. What I will say is, because I was always taught if it's necrotic, it needs to be 2-stepped or multi-stepped. That's what we were taught. But yet I've seen cases here that's necrotic, and it's been 1-stepped and worked. What I will say is, I think symptoms play a part in my diagnosis. So if I see a patient who is symptomatic, a lot of times they're going to get calcium hydroxide to try to calm them down. The second thing is, if they're asymptomatic with the sinus tract, I usually will 1-step those, because I think, and again, I'm going off of my cases, how many times I have problems with this. Those seem to work. But the other thing is if I see a case where I look at the root canal and I think, whoever did this root canal did a pretty good job, and it's not working. Why is it not working? And if I am going to go into those, sometimes those are a lot, well, not sometimes, most of the time those ones are getting calcium hydroxide, because I want to make sure that we get healing from that case. So to answer your question, it's tough to say, because I don't think we know. And there's some endodontists out there that I think have a pretty good beat on what ones do and don't work. And as more and more, as the cases kind of show up, like I said, that Dr. Cotomy out of Durango, I think he has plenty of cases where he's showing this stuff. And as those start to come out, maybe we'll have more of a grasp on it. But I don't think we do. I think, to say we've got it figured out would be...
I think your most dead giveaway of that you have an amazing mind is, so many doctors, they just stand there at the podium like they just know.
Yeah.
But you and I know that if you go back every 100 years back in time, you find out 100 years later that half of what we know,
we didn't really know.
And we know what we know, but we don't know what we don't know.
Yeah.
And you're just so aware that we don't know everything about molar endo in 2015.
Yeah, I agree. That's why I think you have to have an open mind, and you can't be so critical of everything out there, because whether it's, I mean, I learned this very early in my career when I got critical of a general dentist who had sent me a molar endo, and I said, well, why were you doing it? Well, because he could do it. And yet at the time I thought he shouldn't have been doing it, and I was wrong, and so I think that you just have to be very careful, both as a specialist. And as a matter of fact, I think just becoming a specialist doesn't make you any more of a, an expert on it than your general dentist. Sometimes the general dentists understand it better because they realize it's the restoration and the restoring of the tooth that's more important than the actual root canal. Because if you can't restore it, it's never going to go,
But I am a big fan of Regina Hertzlinger, the PhD medical economist at Harvard. And she wrote a book that had a huge impact on me called The Focus Factory. And she did all this research showing that, like when you go to, like, say, a hernia.
Right.
You can totally track that the people who do the most have the highest success rate. And as you even drop down, cut that number in half, the failure rate starts going up high. And Regina Hertzlinger called The Focus Factory. When I read that, it really made me realize that, being a dentist in the old ranch days where you make your own bread and butter, and to be a jack of all trades in dentistry in 2016 ain't going to happen. I mean, how can you master sleep medicine and ortho and endo and perio and implants, even within implants? Bone grafting is almost a specialty.
The headaches that could come if
you just can't you can't be all things to all people. And Regina Hertzlinger's book, read it if you haven't seen it. It's an old one. It's been out a few years on The Focus Factory, but she has the data. And I thought the hernia repair was the most amazing. And she also, the other variables, not only the volume you do, but the amount of time. So if you repair a hernia in 5 minutes, you almost have a total success rate. By the time it takes you 10 minutes to do it, you have like a 5% failure rate. And then by the time it takes you a half hour to do it, 20%, because, think of pulling 4 wisdom teeth. Like an oral surgeon go in there and pull surgery time, all 4 of them in probably 10, 15 minutes. A general dentist might be spend an hour getting 1 out. Guess who's doing higher quality? That the people who know what they're doing the most, have all the instruments, all the knowledge, and they have the quickest times. And the faster you do it, the higher success rate. So the speed at which you do it, the volume at which you do it is highly associated with how well you do it. But hey, man, seriously, thank you so much for spending an hour with me. You didn't have to do it. Thanks so much. And I'm sure they all enjoyed it. Thank you very much.
Thank you.
Bye-bye.